You have a woman that wants bariatric surgery because she's obviously obese and she wants to get pregnant after she gets the bariatric surgery done. So what do you tell her? Well, in a person who's obese like that, we would go ahead and recommend bariatric surgery if nothing else has worked, because obesity in and of itself can lead to a lot of complications during pregnancy. So go ahead and give her the bariatric surgery, but she cannot get pregnant, or she should not get pregnant, for about a year after her bariatric surgery was done. So we know that there's going to be malabsorption, nutritional deficiencies after the bariatric surgery. So she needs to stabilize her nutritional status and get everything to a nice status quo level before she gets pregnant. And so what we're going to do is, after we do the bariatric surgery, we're going to give her a non-oral form of contraception, because oral contraceptive pills will have decreased absorption with the bariatric surgery that was done. If you have a mother who's pregnant with diabetes, the complications that can occur to the newborn will be dependent on whether the hyperglycemia is present in the first trimester or in the second to third trimesters. So in the first trimester is when a lot of the damage can be done, with congenital heart disease, neural tube defects, a small left colon, or spontaneous abortion. In the second to third trimesters, the neonate will survive that, but once they get out, they will suffer from fetal hyperglycemia and hyperinsulinemia. And what is this going to cause overall? I mean, number one, macrosomia. The baby's going to be big, and because of that, you can have some complications during delivery, such as shoulder dystocia, which can result in injury to the brachial plexus, clavicular fracture, or perinatal asphyxia. Another thing that will happen due to the hyperglycemia and hyperinsulinemia is increased metabolic demand, which can cause erythropoiesis and lead to polycythemia vera. Another thing is glycogen synthesis. So insulin is going to stimulate glycogen synthesis, and this glycogen has a propensity to depositing itself in the intraventricular septum. So this can cause hypertrophic cardiomyopathy and will be evident once the newborn is born. And this will be present with respiratory distress, your typical things of tachypnea, nasal flaring and retractions, a heart murmur, and this is all indicating hypertrophic cardiomyopathy, which is found in mothers with gestational diabetes. Talking about that previous case, you don't really have to do much about it in terms of treatment. It will resolve by itself within a few weeks once the insulin levels in the newborn normalize. Next situation, you have a patient that comes in with an MI, and you see ST depression, or elevation, I should say, in leads 2, 3, and AVF. This is telling you that you have an inferior wall myocardial infarction that is caused by a blockage in the right coronary artery. For 60% of patients, the sinoatrial node is supplied by the right coronary artery. It will be evident if this patient, if they are one of those 60%, it will be evident in the fact that they will present with bradycardia on top of their myocardial infarction symptoms. So the question now is, what is a treatment modality that you can do for this person to prevent the bradycardia from getting worse or exacerbating the situation? So basically what you want to do is you want to block vagal tone by giving an anti-muscarinic agent. The anti-muscarinic agent of choice in this situation would be intravenous atropine sulfate. Did I say anti-muscarinic? I meant anticholinergic. They're the same thing. Anti-muscarinic is a more specific type of cholinergic receptor. In this case, atropine is an anti-muscarinic drug. I should add that in this situation that we just covered, bradycardia by itself is not an indication for the administration of atropine. You have to have hemodynamically significant bradycardia, so a decrease in blood pressure and or clinical signs of pulmonary edema, such as crackles on lung auscultation. All right, next we got a dermatology situation. So this is going to be a patient that is complaining of scaly skin that is sometimes pruritic. And when you look at it, it has like these dark, scaly patches that are usually present on the extensor surfaces of the legs. The condition arises somewhere around childhood and continues into adulthood and is an inherited disorder. So there's going to be a family history of it as well. And basically, this is caused by, so there's a gene, a filaggrin gene, and essentially what happens is that there's not enough desquamation of the keratinocytes. So there's going to be a bunch of keratin deposition and not enough removal. And this is also accompanied by epidermal hyperplasia. And so you're going to get these gray fish-like scales that they're described as, rough and dry. And so basically the way you're going to treat this is a lot of exfoliation with long baths, and you do moisturization and use of lotions known as keratolytics, right? So they're going to remove the keratin, and they typically contain urea, alpha hydroxy acid, or salicylic acid. All right, let's take this time for a quick review of Turner syndrome. So Turner syndrome is characterized by short stature, narrow or high arched palate, a webbed neck, broad chest with widely spaced nipples, cubitus valgus, short fourth metacarpals, congenital lymphedema, and a low hairline. When you have a patient that's born with this, there are a few things that you're going to have to check for as they grow through life. 4 extremity blood pressure measurements, all 4 limbs, and echocardiography. And the reason for this is looking for aortic coarctation, which is essentially narrowing of the aorta after it has passed the 3 great vessels. So after it has given rise to the right subclavian, the left carotid, and the left subclavian. And so in this, you'll see high blood pressure in the upper extremities. Another thing is ultrasounds being ordered for screening for horseshoe kidney, which can predispose to urinary tract infections. Another thing is screening for hypothyroidism, celiac disease, and there's also overall increased risk of autoimmune conditions such as those two. In addition to that, there's increased risk of learning disabilities. So there is neuropsychological testing that is done prior to school entry. However, one of the things that a question may ask you is whether or not this person is going to have normal intelligence. Just because somebody has learning disabilities does not mean that they have decreased intelligence. And this is one of those situations. So a person with Turner syndrome has normal intelligence. Now, according to the current medical literature, the cause of Turner syndrome is due to non-disjunction, and this is basically going to result in a monosomy X. So only one X chromosome. The other X chromosome may be completely absent or damaged so that there's a partial loss of it. This happens in 1 out of every 2,500 live female births. There is no propensity to have Turner syndrome, to have another baby with Turner syndrome after you've had a baby with Turner syndrome. So if somebody wants to know whether they have an increased risk of giving birth to a baby with Turner syndrome because they've already had that, the answer is no. If you have a patient that has sustained a hip fracture, which is usually something that's happening in older patients, and they were ambulatory before the hip fracture, okay? You want to do surgery to repair that immediately. Don't wait. You want to do it within 24 hours. This prompt surgery is associated with decreased mortality, decreased length of hospital stay, and decreased time to full weight-bearing status. So you want to do that, okay? Now, it doesn't matter if they have a bunch of morbidities, diabetes, coronary artery disease, whatever it may be. If they were If they were mobile beforehand, do the surgery. Okay. Now, there are situations where you want to delay it. The only situations where you want to delay it is if the person has acutely unstable medical conditions, such as infection or unstable angina, something like that. Okay. But you don't want to delay it for greater than 72 hours. You want to keep it within that 72-hour window. All right. Non-operative management, very high mortality, about 4-fold increase in a year. You do that for patients that were non-ambulatory beforehand. Okay. One thing I should add, doesn't matter where the hip fracture is, whether it's intertrochanteric or femoral neck fracture. An elderly person, just fix it immediately. Stress urinary incontinence is exactly that. You pee whenever there's stress, physical stress on the abdomen or the pelvis with the Valsalva maneuver, or from coughing. And you can use the cough stress test as a screening tool to see if this is the case. One of the ways in which questions may test to see your knowledge of this is understanding the pathophysiology behind it. So, increase intra-abdominal pressure with age-related connective tissue loss can cause inadequate urethral support. And so the urethra becomes hypermobile. So urethral hypermobility is the key phrase here that you associate with a patient that shows the signs of stress urinary incontinence. PCP. Don't forget how to recognize PCP. Nystagmus, high blood pressure, tachycardia, and obviously the rest of the behavioral symptoms that can last anywhere from 7 to 8 hours. If the patient's doing all this crazy stuff, you can pretty much say that they have PCP intoxication. If they start getting dangerous and violent and aggressive, just give them a benzo, give them lorazepam, call it a day. You have a patient that comes in and all of a sudden they have these neurological symptoms: leg weakness, paresthesias. You start doing a neurological exam and you can see that there's a specific level at which the neurological symptoms begin and end. What could be going on with this person? I mean, when I'm talking about lower extremity, you may think of Guillain-Barré syndrome, especially if there's like an upper respiratory infection somewhere in the history. But there's another entity that you need to be aware of, which is known as transverse myelitis. If you have this very clearly demarcated sensory level, then it's more suggestive of transverse myelitis. What you do in this situation is you do an MRI. Okay? Because Guillain-Barré syndrome, which is what you'll do, you'll test for Guillain-Barré syndrome with nerve conduction studies. But that acute sensory level right there is what gives it off. Okay? And also if there's bowel bladder dysfunction, that also gives it away too. That's more suggestive of a myelopathy that is not GBS. So in that case, what you'll do is a gadolinium enhanced MRI of the spine. Okay. You want to rule out structural abnormalities, compressive myelopathies, essentially. If there's no evidence of a compressive myelopathy, then you use the gadolinium enhancement to see if there's an inflammatory myelopathy. If there is, then continue the workup down that route, do CSF testing. If there's not any indication of gadolinium enhancement, which doesn't show any inflammatory myelopathy, then you do a lumbar puncture to see if you can find some sort of cause of non-inflammatory myelopathy. If you see that there is inflammatory myelopathy, that there is transverse myelitis, then You treat with high-dose corticosteroids for 3 to 5 days. If there's suspicion of compressive myelopathy, you also treat with steroids.